Good morning. Sorry, I have taken permission to do my presentation first because I have to check out from my hotel, and I have taken the permission from the organizers. At the outset, let me thank the organizers for allowing me to make this presentation. I'm going to talk about magnitude of refractive errors and causes of visual impairment among school children in 3 districts in Sri Lanka. There is no conflict of interest to declare. Now, visual impairment in childhood has a negative and an irreversible impact on the child's development, which can persist into adulthood and affect the quality of life of the individual. So, various studies give different causes of visual impairment. This depending on the population studied, whether they are urban or rural, whether the country is developed or underdeveloped, and strategies for prevention within each health system. And generally, uncorrected refractive errors and cataract usually are at the top of the list. Now, 40% of children are blind from preventable eye conditions, and this could have been prevented by having comprehensive services at all levels. And it is known that spectacles is a very cost-effective model and will reduce visual impairment in children. Now, Sri Lanka has an established comprehensive school health and nutrition program. It is conducted in government schools by the state-run primary health services. And identification of visual defects and referral to a regional eye center is a component of this program. But the shortcomings are only a certain percentage of children are screened annually, and the purchase of spectacles is an out-of-pocket expense. So we conducted this program between 2022 and 2024. The aim was to strengthen the existing school screening program, evaluate and treat children with visual impairment, and provide spectacles free of charge in children in these 3 chosen districts in Sri Lanka. In these 3 districts, the population is underprivileged and resource poor, and we were supported by the government through the Ministry of Health and Ministry of Education, and an international donor supported us with funds to provide free spectacles. And these are the 3 districts that we have covered. So our aim, now we have done this study from the data obtained from that program. Our aim was to identify the extent of visual impairment among these school children and causes of visual impairment and the magnitude of refractive errors and refractive amblyopia, and to see whether the already existing service are actually effective. So our population range from 5 to 20 years, because sometimes children stay in school because they sit for the advanced level examination 2 or 3 times. And the public health staff screened these children using the Snellen's visual chart, and any child with visual acuity less than 6.6 in either or both eyes were referred to a camp where they underwent refraction and comprehensive eye examination conducted by a consultant ophthalmologist. Those who needed further intervention and cycloplegic refraction were referred to the nearest clinic, and those who needed spectacles were issued spectacles. And we have screened over 300,000 of children in these districts. In some districts, our coverage was very good, but in other districts, because actually the donor wanted to withdraw from the program, we have covered only high-risk groups. So now we have categorized refractive errors: myopia, hypermetropia, astigmatism, bilateral amblyopia, and unilateral amblyopia. That was what we used. And as in the other areas of the world, in our study population also, the refractive errors were the top of the list. But we analyzed the refractive errors. We found that astigmatism was commoner than myopia in our study population. And we also found that there were only very few cases of refractive amblyopia. Now, we have not got all the data yet, because some of the data is unrecovered, and we are in the processing of obtaining and analyzing this data. But what we found is different from what others have found from studies in this region, because our highest in our population, the astigmatism is higher than myopia, and because the refractive amblyopia we saw only a few patients, probably the services in existence are effective, and the main obstacles to our school health program is the distance the child has to travel to obtain eye care services and the out-of-pocket expense in obtaining spectacles. So we need to develop a more sustainable program, at least for children in rural areas with limited health resources and economic constraints. These are my references, my acknowledgements. Thank you for your kind attention. Thank you.
Dr. Vivek will talk about decadal trends in distance effective refractive coverage in India. Vivek.
Good morning all. Thank you very much for this opportunity. So, no conflicts of interest. Now, distance effective refractive error is a recent global indicator for assessing global eye health and universal eye health recommended by the World Health Organization. It refers to proportion of people who have received refractive error services and have a good quality outcome. So basically they are not visually impaired with the use of glasses. The formula has been given, and the challenge is that commonly used survey methodologies such as the rapid assessment of avoidable blindness methodology, they do not measure the uncorrected visual acuity or UCVA. So we cannot estimate effective refractive error coverage if uncorrected visual acuity has not been measured. The global effective refractive error coverage at 612 threshold of visual outcome has been estimated to be 35.7% by the World Health Organization, higher in men and reduces with increasing age, and it varies by by the WHO region. However, for Southeast Asia region, if you see, the estimate by the WHO is very high at 75.8%. But this is in population aged 50 years or more. So our objective was to collate data from various population-based studies in India and estimate how much is the effective refractive error coverage in our country, in India. This was a secondary data analysis. We collated individual level de-identified data from all the population-based surveys that were conducted by Dr. Rajendra Prasad Center in the period 2001 to 2024. So 24 years of surveys were taken, and we extracted all the survey metadata as well as the individual level de-identified data. We did data transformation and recategorization because the metrics for assessing visual acuity were different across the surveys. The causes of visual impairment were different across the surveys. So we standardized all of those. And thereafter, using the standard formula for effective refractive error coverage, we estimated the coverage as well as overall as well as in various subgroups. So what were our results? So we had a total of 275,000 individuals represented in nearly 20 surveys which were there. But as you can see, the green rows, these are the ones which represent the where the gray rows represent the surveys where uncorrected visual acuity was assessed at 6/12 cutoff and distance glass use was available. So that was 8 surveys representing 48,000 individuals, from which we could estimate effective refractive error coverage. Though 45% of these individuals were males and 45% of the sample was urban sample. In India, we know urban is just around 1/3, so there was slight overrepresentation. How we estimated EREC is by the standard formula A upon A plus B plus C. So the met need A out of these 48,000 odd was 1748 individuals. Under met need, individuals who are using glasses but have poor visual outcome was 307, and total unmet need, people who require glasses but are not using glasses, was 5,161 individuals. Overall effective refractive error coverage was 24.2%. If we look at distribution by age group, so we had under 40 sample where the coverage was very high, close to 80%, But if you look at sample over 40 years of age, the coverage is ranging around 19% to 30%. It is decreasing as the age is increasing. And if you look at gender, the coverage is higher among males compared to females. All these differences were statistically significant. Rural-urban differences were observed. Urban effective coverage was higher than rural. And if you look at trends over the years, the midpoint of the survey, then there is an increasing trend which is clearly visible, increasing from 10% to nearly 40% plus minus in the recent surveys. If we did a multivariate analysis, so there also all these differences were statistically significant. And if we specifically look at the last row, we can see that the odds of coverage, effective coverage was nearly 3.5 times in the 2020 and recent surveys compared to the older surveys, indicating that we have done a substantial progress in our country. So if I have to summarize the results, the overall effective refractive error coverage in India is high at 32.7%. This is a significant increase compared to 13.2% in the pre-2010 surveys. It is more in urban areas compared to rural areas, and this is the largest analysis of Indian data set over 2 decades. We definitely have some limitations. There are geographical variations in coverage which are there, because certain parts of the country have higher access to eye care services compared to other areas. We had a limited sample size, especially in the under 40 age group. And there are obviously a lot of confounders which are there, which may operate at individual levels, which we could not analyze because of lack of data. If we compare with the other published literature on effective coverage, now the study number 1st and 3rd are included as part of this analysis. These were our publications only. So I will refrain from comparing against those. But if you look at data from Nepal, they also had 34% coverage recently. And in South India and Telangana was 37% was the coverage which was observed. So our results are in line, recent results, with our other studies from the region. And these are definitely lower than what WHO has predicted for the Southeast Asia region. So to conclude, effective refractive coverage in India has improved over time. We have to monitor this target. This is a global monitoring target. So we need further national level assessments with standardized monitoring for assessment. Thank you.
Thank you, Vivek, for this extensive study and data collection and data analysis. Just one query from my side. Can I ask question now? Is it rapid fire? What about the near effective refractive coverage for presbyopia? Are you able to manage that also? Or?
Okay, so that's an excellent question. The problem is all the initial surveys or the rapid surveys, they did not include near vision assessment as part of the standardized methodologies. That said, the recent methodologies, the RAP7 and the rapid assessment of avoidable visual impairments, they include near vision assessment. So yes, there is a potential for looking at recent data for near coverage, but not really for using older data.
My query is whether RAP survey is possible to collect effective refractive coverage through RAP survey?
The most recent version, yes, not the old version. RAP6 till RAP6, the indicator could not be assessed.
Thank you very much. I believe it's a rapid fire, so question should be avoided. I would like to invite the next speaker. Is it Murada Sharadin? Is she there? Oh, sorry if I am pronouncing it wrong. The prevalence of visual impairment and its causes in adults aged 50 years, Malaysia. Yeah.
Good afternoon, everyone. I'm Dr. Siti Nahoda from Ministry of Health Malaysia, and I'm honored today to present Malaysia's journey in achieving universal eye health through findings from national eye surveys in Malaysia. There's no conflict of interest related to the study. So blindness is a major public health concern, with cataract being the leading global cause. Malaysia has long recognized the urgency of reducing the blindness. And then it's central of the endorsement is endorsement of the resolution WHA in 2013. So to support that, we conducted National Eye Survey 2 in 2014. It's a nationwide population survey covering the simultaneous 6 surveys across the country. And one of the objectives is to measure the prevalence of visual impairments and its causes in adult age 50 years and above. So we use a cross-sectional population-based survey employing the WHO recommended RAP methodology. So in 2014, NEST2 showed that we would like to highlight the regional variation in prevalence of blindness across the country. As shown in the graph, the Sabah reported the highest prevalence of blindness, which is 1.9%, with the main cause of blindness is still cataract, which is more than half, 58%. And also we also noted gender difference, particularly in Sarawak and also Eastern Zone. In Sarawak and also Eastern Zone, where female has significantly higher prevalence of cataract blindness. Same goes to the prevalence of low vision across Malaysia. So we can see the similar pattern, with cataract being the most common cause of visual impairment in moderate and also severe. So to address this gap, the Ministry of Health has introduced a mobile cataract unit in 2 zones, which is Sarawak and also the Eastern Zone, so to reduce the cataract backlog. So this is a photo of the mobile cataract unit traveling at the remote area in Sarawak region. So, and we are honored that our effort has regained international recognition by the WHO on its innovative approach in bringing high impact, good quality and low cost care closer to home in 2023. So after 10 years of our dedicated work, it's time for us to evaluate the effectiveness of our intervention. Therefore, we conducted a National Eye Survey 3 in 2023, which focusing on 2 zones in Malaysia, which is Sarawak and also Eastern Zone, which both served by the mobile cataract unit. So as we compare from National Eye Survey 2 and National Eye Survey 3, there's a tremendously reduction of prevalence of blindness in Sarawak and also Eastern Zone. So in Sarawak, it's reduced from 1.6 to 0.6, while Eastern 1.4 to 0.8% of prevalence of blindness. But it's noted that cataract still remains the leading cause of blindness. And there's also no gender difference in this survey. Same goes to the level of visual impairment. Severe visual impairment showed a decline in both zones, while moderate visual impairment, there's a slight marginal rise in the Sarawak zone, while a notably rise in the Eastern Zone, with untreated cataract still the leading cause of main visual impairment in severe and also moderate. So some progress has been done, but we still there's much that need to be done. So because cataract is still a leading cause of blindness and also severe visual impairment in Malaysia, as the population age is still on the rise. So we are recommending to expand our eye health in terms of awareness and also intervention to cover more through multiple collaboration with local and also international partners. So our goal initially is to enhance the equity of eye health services so that no one is left behind in fighting against avoidable blindness. And with that, I thank you.
Thank you very much for providing details about Malaysia. Happy that blindness is reducing there, but you need more efforts for cataract surgery. Thank you very much. Now I would like to invite the third speaker, Shubharata Hegde. Yeah, she'll be talking about cataract conundrum, barriers to early uptake of surgery. Yeah.
Good afternoon. Cataract conundrum, early surgery uptake barriers. I have no financial disclosures to make. With continuing development, cataract surgery has become one of the safest, most predictable and cost-effective healthcare interventions. Yet, cataract is the most common cause of blindness worldwide. Only 17% of the patients with cataract blindness have access to surgery. The Government of India under NPCB has taken several measures to reduce blindness due to cataract. India has high cataract surgery coverage with 65 lakh cataract surgeries being done every year. Yet, cataract continues to be the major concern to India. untreated cataract continues to be a major concern to India. So the aim of this study was to identify the barriers for uptake of cataract surgery services among patients with bilateral mature cataract. We chose these patients because these are the patients who delayed seeking treatment until it became inevitable. It was a prospective study of 1 year duration. All patients with bilateral mature cataract were included. A detailed history and relevant information was collected with the help of a questionnaire. Coming to the results, a total of 54 patients were included in the study. Majority of the patients were elderly, with 75.9% of the patients being aged more than 60 years. A slight female preponderance was seen. The literacy level of the patients was very low, with 92.6% of the patients having no formal education, and most of the patients resided in the rural areas. Most of the patients were unemployed and belonged to low socioeconomic status. The duration of bilateral blindness was 3 months or more in 82% of the patients, and hypertension was the most common comorbidity seen. When we asked the reason for not seeking early treatment, fear of surgery was the most common reason cited, followed by transportation difficulties and lack of awareness. When we compared the reasons for delay between males and females, fear of surgery was the most common reason cited while by females, whereas the transportation difficulties was the most common reason cited by males. When we compared the reasons for delay between urban and rural population, fear of surgery and transportation difficulties were the common reasons cited by both the groups, while lack of awareness was cited only by rural patients. So these were the major barriers identified in our study. 3/4 of our patients were elderly. Studies have found that prevalence of unoperated cataract are higher in elderly population. The presence of comorbidities and increased dependency in this age group are the contributing factors. Most of the patients hail from rural areas in our study. This is in agreement with the study conducted by Lipi Chakravarti in central India. So the reason for this may be that the eye care facilities providing surgical treatment are usually located in towns and cities. The literacy level of the patients in our study were very low. Low literacy means less access to information, therefore poor utilization of services. Fear of surgery was the most common reason cited in our study. This has been identified as an important barrier for cataract surgery uptake in many other studies as well. The fear of surgery may be due to lack of knowledge about the surgery, concern about the quality of the surgery, or knowing someone who had an unsuccessful surgery. Lack of awareness about the available treatment for cataract surgery was cited only by rural patients. This may be because of the low literacy levels in these patients. Low socioeconomic status was another major barrier identified. Most of the patients in our study were unemployed or daily wage workers. For them, going to hospital to seek treatment means loss of income. And transportation difficulties was a common barrier identified by rural residents. The limited public transport facilities available in the rural areas may be a reason for this. A slight female preponderance was seen in our study, but it was not statistically significant. However, many other similar studies have found female gender as a major barrier to access cataract surgery. To conclude, most of these barriers are interrelated. So, a multifaceted approach is needed to address their diverse nature. Barriers for early uptake vary from region to region. So, planning needs to be done at the local level. Eye care services should be people-centric and closer to community. Availability of cataract surgeons and quality cataract surgery facility in rural areas will eliminate many of these barriers. All the advancement in cataract surgery becomes meaningless if it does not reach the intended population. So none of them should suffer from the darkness of cataract blindness when the treatment is available in the form of a safe and simple surgery. Thank you.
Thank you so much, Shubhrata. In fact, all these are more commonly known facts. And what solution we feel is if we involve ASHA workers or volunteers, probably most of these barriers can be resolved. Thank you very much.
Thank you.
Now I would like to invite next speaker is Shopping Yang. She's here? Not here. There are two presentations from her. Then Juping Liu, not here. Kong Ye, the entire group has gone. Pradeepa Srivardena, she has already done, I believe. Alina Yakupova. Yeah, it is there. Thank you. This is age-related macular degeneration, epidemiological characteristics in southern Urals. Yeah, please. Thank you.
Can you hear me? Thank you for the opportunity to take part in this Congress. My name is Gyuri Kazakbayeva. I'm the head of Epidemiological Department in UFA Research Institute, and my topic will be devoted to the prevalence of AMD in South Urals, that is in Russia. This is my financial disclosure. So according to the results of the meta-analysis based on 39 population-based studies, the number of people suffering from AMD in the world is growing rapidly. In 2014, the number of patients with AMD globally was about 64 million. In 2020, 196 million, and by 2040, this number is expected to be 288 million. On the basis of our UFA Research Institute, a cross-sectional population-based studies, oral eye medical study, was conducted to analyze the influence of various factors on the development of certain eye disease, and to study the anatomical and functional features for the eye among the population in South Europe. In the Euro Eye medical study, there were 7,000, almost 6,000 participants with the participation age rate 80.5, with age 40 years and older. Data analysis was carried out on the assessment of 683 criteria, including 355 ophthalmic ones. Examination methods are presented on the slide. Among all the study participants, almost 6,000 participants, 3.1 suffered from mild visual impairment. Also, 3.1 of individuals suffered from moderate to severe visual impairment, and 0.19 of individuals, they were blind. Visual acuity was assessed in the better seeing or single eye. Among the respondents, those were identified who had signs of any disease of the organ of vision that could lead to one or another degree of visual impairment and blindness according to the WHO classification. In this case, visual acuity was assessed on the better-sided or single eye. In the case where one eye had several diseases, the visual acuity, the visual impairment was assessed, just a moment. Sorry. The prevalence of all stages of AMD was strongly associated with older age in the study population. The prevalence of any AMD and late AMD increased from 10.2% and 0.4% respectively in the age group from 55 to 60 years, to 37 to 38% and 9% in the age group of 80 plus. Higher AMD prevalence in our study population was correlated with older age, rural region of habitation, lower diabetes prevalence, and shorter axial length. So to conclude, the prevalence rate of AMD of any stage in total study population was 10.5 and was strongly associated with age. In this typically ethnically mixed urban and rural population from Russian Federation, a higher AMD prevalence was mainly associated with older age, rural region of habitation, shorter axial length, and a lower prevalence of diabetes mellitus. Thank you.
Thank you very much. In India, we have done AMD study mainly in 60 plus age group. You have taken 40 plus age group.
Yes.
Probably the 40 to 60 group may have very less prevalence of AMD.
Yes, that's right.
Yeah. Thank you very much. Thank you. We have the next speaker, Nijamudnova.
Yeah,
No.
I will do the same presentation.
You will be presenting her. Prevalence and associated factors of diabetic retinopathy in adults.
So same, dear colleagues again, so same study, and we also evaluated the results on the prevalence of diabetic retinopathy. This is also an important topic because diabetes is one of the leading causes of disability and death worldwide.
In the recent Global Burden of Disease study, diabetes rose from 13th place in 2010 to 7th place in 2020 and 2021 in the ranking of the most common global case of disability-adjusted life years lost. Disability-adjusted life years is a metric used in health economics. It measures the burden of disease as the number of years lost due to poor health, disability, or premature death. According to the systematic study of the prevalence of diabetes from GBD study, the percentage change in disability-adjusted life years from 1920 to 2021 for diabetes in Russia was 200%. As the most common and specific complication of diabetes, diabetic retinopathy is also one of the leading causes of preventable blindness in the adult working population. The GBD study showed that in adults aged 50 years and older, DR accounts for 18.5% of all diseases, and it's the fifth leading cause of blindness and moderate and severe visual impairment. Also, DR is important for visual impairment. There has been no information available in the prevalence of DR and those stations in the whole population in Russia. That's why we performed this same population-based study with 6,000 individuals of participated, same age, 40 years plus. Among participants, there were 42% of urban residents and 59% of rural residents. In this study, we used the generally accepted classification of diabetic retinopathy approved by the World Health Organization, according to which two forms of retinopathy are distinguished, non-proliferative and proliferative. Of the total number of subjects in this population study, 577 individuals with a history of diabetes mellitus were selected. 89 of them had type 2 diabetes. The study also provided data that confirmed the relationship between diabetes and its risk factors and consequences, such as older age, increased body mass index, arterial hypertension, increased blood lipid levels, cardiovascular disease, and others. The prevalence of diabetic retinopathy in the study population with diabetes was 17%. Non-proliferative diabetic retinopathy was detected in 96% of cases, proliferative diabetic retinopathy in 4%. The prevalence of diabetic retinopathy within the study population was higher in women and amounted to 65%. The proportion of rural residents diagnosed with diabetic retinopathy was higher and amounted to 59%. The prevalence of diabetic retinopathy in rural population is probably due to the lower rate of medical care sought by population, and we maybe think that it's lower availability there. It was also found that diabetes was most common in the age group of 55 to 69 years, and diabetic retinopathy also was prevalent among people aged 85 to 89 years. So to conclude, the prevalence of diabetic retinopathy in the typically ethnically mixed population of Southern Europe that we can extrapolate to Russia was 1.7% among the population aged 40 years, which was relatively lower than the global characteristics. Diabetic retinopathy showed an inverted U-shaped association with age. The prevalence of diabetic retinopathy in women was higher, and it was higher in rural residents. Higher prevalence of diabetes was associated with older age, higher prevalence of BMI, a positive history of arterial hypertension, and higher concentration of triglycerides in blood serum. Thank you very much, and I invite you to take part in the 15th International Conference that will be in our city, in Ufa. Thank you.
Thank you so much. Just one query from my side. What was the proportion of blindness and visual impairment due to diabetic retinopathy? And second, what is the proportion of diabetic retinopathy leading to sight-threatening DR? You have these figures?
Yes, we have examined this. I don't have the data now with me, so I can send you all this data if you...
Sure.
Yeah,
Thank you very much. I think the next speaker is Rohan Khemlani. Yeah, please, Rohan. Overcoming barriers, portable eye care in a nursing home setting. Yes, that side is fine. Yeah, sure.
Okay.
विवेक इसके बाद तुम्हारा एक और है.
Okay. Okay, let's begin. Ladies and gentlemen, thank you for your attention. Last day, a little bit left. Let's get through. So, my name is Rohan, and I'm part of these affiliations. And these are my colleagues. We all work together in Tokyo, Japan, and we also do a lot of work in rural areas of Japan, and as well as in central areas where there's a lot of older populations, right? So they're quite immobile. Yeah. Thank you. All right, so conflict of interest. I am an employee of one of the affiliations. So Japanese life expectancy, right? The highest in the world, and there is a big rise in need of home care physicians. And actually in Japan, they're the ones who take care of patients in the elderly houses or nursing homes. And portable equipment and telemedicine are key for patients with reduced mobility. Now I know in South Asia, telemedicine is not as prevalent officially because people just send the images through WhatsApp. But in Japan, the data privacy is extremely strict. So we need something official. And of course, in rural areas, it only gets worse. So the case is essentially of a 87-year-old woman. She presented with foreign body sensation, and we used these two particular pieces of portable equipment and followed up on her for a period of over 1 year. So the first is called the Smart Eye camera. It's a smartphone-based slit lamp microscope. You put an attachment over an old smartphone, and the light that comes out of the phone, it's converted into a slit, and it generates essentially a slit image. And the other is the eye care tonometer. Maybe some of you are familiar. It's just a portable tonometer, measures the IOP. So what we found essentially throughout, various stages of screening this particular woman is that first she had, a lot of swelling. And we use that Smart Eye camera to take images, and the Smart Eye camera allows to take images in 3 modes: the diffuse white light, the slit light, and a blue light version, of course with some staining applied. And these were our findings. And with the tonometer, we found out that IOP was in the normal range throughout, so we didn't really worry about it that much. And so, we had, of course, had eyelash removal, we applied lubricants, and various surgeries are under consideration because there are multiple complications of this patient as well. And, this really case underscores the importance of accessible eye care services in vulnerable populations. And here's where I would like to make one point. So eye camps in, Asia overall, in more in South Asia, are quite prevalent. But in developed nations like Japan, that's really not a concept, right? Because the services are quite, available and sufficient for people, and the government services are really supreme. But because of the massive elderly population in the nursing homes, they are immobile. So essentially it becomes the same thing, and that's where the portable equipment are really of use. And really quick about the Smart Eye camera, it's, essentially it's just an old iPhone 8. We put this over it, and now you have a slit like this, essentially. Yep. And, it's lightweight. You can see it. It's just essentially a phone, and it leverages the camera and the flashlight of the smartphone. So that's where a lot of the, compactness comes from, because you don't have any external peripherals other than the attachment itself. And there's also telemedicine and AI. So as I said, in a lot of other countries, official telemedicine services are very important. So we just upload the video in the software. We have a software. Upload it to the cloud. You can request a diagnosis from another registered user that you allow to access your data. And in the chat box, they can give you feedback. And the AI, very simple. Same again. It's uploaded to once the video is uploaded to the cloud, we press the icon, and there is cataract grading and detection, as well as ACD measurement. Soon dry eye and anemia detection coming up as well. And so the functionality is at 3 levels. Portability, of course. Then telemedicine, you don't need a specialist at the location, and the AI, you don't need a specialist at all. And so we really pride ourselves on being evidence-based. We are constantly publishing various papers, whether validating the device itself or using the device in various settings. I myself was part of a really big study 2 years ago in Nepal. I am very close to publishing the paper myself. We screened a bunch of kids using the Smart Eye camera and some other portable equipment. So we're always looking for research partners to join us. And so I'm going to be out of time soon, but more or less, there's a big number of preventable, blindness in the world, and it doesn't happen because of lack of access to personnel and other resources, and this is the bridge, this is the gap that we're trying to bridge. So thank you very much for your time, and please let me know if you have any questions. Thank you.
Dr. Vivek, please.
Excellent presentation. Thank you.
Thank you, sir.
Have you considered looking at corneal opacities detection using the same anterior segment?
Yes, sir.
That you're doing?
Yeah, great question. So of course you can, if you as an eye specialist use the device, you'd be able to look, you'll be able to get a general idea of if they're, about corneal opacities. But the more exciting part is, I just mentioned dry eye and anemia, but corneal opacity AI detection is on its way. There is actually a paper published about that, using the device. So I can actually give you the link later. Yeah.
Thank you.
Thank you, though. Thank you.
Is this also taking fundus photograph or no? Not.
Oh, okay, yeah. So this particular one is for the anterior segment, and that's actually what I use most of the time because that's my part in the team. But there are 2 models which also look at the posterior segment. One is the direct fundus, the other is the indirect. And the indirect one is still a prototype. It's only in research and development phase. But the direct one, it's actually out now. It's developed. We actually had a booth, and we were displaying it there as well. And can it be on Android platform or something? Yes, sir. So that's one of the bigger limitations. Unfortunately, it utilizes the lens and the flashlight, so it has to be of this shape, single camera. So right now it's iPhone, and from the old ones, it's iPhone 7 and 8. From the newer ones, it's SE2, SE3, special edition. It's not so common in India, but you could find it. We're working with Oppo to, make a model with them. I just saw the prototype and, the cameras, it's, next level.
So this phone cannot be used?
Unfortunately not, sir, yeah. But we do, there are two issues. So first of all, we do give with the phone. We provide the phone. And the second thing is also, since this whole project started in Japan, the local doctors don't like to use their phones. They want to keep it separate in the first place. So we thought, it helps. And in Japan, it's also, pretty easy to get an old iPhone 7 or 8. Here, 7 might be hard. 8 you might still be able to get, but 7's nearly impossible to get here. Yeah.
What about the cost of this attachment?
Yes, sir. So with the phone, the attachment, the software, AI, everything, there's different packages sort of, but in INR, it just for the anterior segment, altogether, it's about 60,000.
60,000.
The only thing is, though, if somebody buys it from us after today, after the conference, India doesn't allow imports of iPhones. So we can send the attachment, and we can, help you with the software and everything. But one would have to procure their own compatible phone here. Refurbished ones go for about 5 to 6K, iPhone 8s, I think, good ones. Usually we do ship it with iPhones, but India doesn't allow. So we're not able to do that.
Thank you very much. I'm sure Dr. Vivek would like to have some collaboration with you.
I'd love to,
AIMS New Delhi will be happy to.
Thank you. Yeah, we're also looking for research collaboration, so not just for sale. So we'll give you the device for free for the duration of research. And of course, you collect the data in a few days, couple of weeks, and for the rest of the time you have it for your
I think we're concerned only with research, not nothing for sale actually.
Sure. Yeah. So actually one of the, if you don't mind, just really quick, last thing. My bosses are not here. They might not like me saying this, but what we end up doing a lot of times, what happens is, we give the device for research for a year or two, whatever the duration is. And people collect the data in 2 weeks. Now they're still over 100 weeks, and they just use it in their clinic, and we turn an eye. It's okay, no problem. And then officially we're supposed to get it back, but then our research partners just do another project. So essentially they just, in that manner, they end up keeping it. We actually did a project with Arvind Eye Hospital 2 years ago. There's a paper published in the Indian Journal as well. Yeah.
For the clinicians and outreach activities also, this is like
It is mainly for outreach activity in teleophthalmology base.
Yes, sir. Yeah. Outreach, yeah.
alternative to handheld system, which is like robust and all things.
Yeah, that's the point. Yeah.
I think we
Thank
should
you.
finish. Thank you, Rohan.
Sure,
Thank
sure.
you for
Thank you,
nice
sir.
presentation.
Thank you, guys.
And the
Thank you for
last
your time.
presentation by Dr. Vivek Gupta, burden of visual impairment associated with refractive errors among school-age children in India using machine learning approach. Vivek.
Thank you. So, no conflicts of interest. So, as we are all aware, undercorrected refractive errors are one of the leading causes of visual impairment globally, causing 41% of MSVI. And there is a very, very high prevalence of myopia that is the primary driver for refractive impairments. Our meta-analysis in 2020 showed that 8.1% of Indian children have myopia, so definitely the prevalence of refractive errors is going to be higher. The REACH study, which was the largest study among school kids in India with 2 million children enrolled, they had 5.7% screen children reporting myopia. But the state-wise data in India is not available. If we talk about the REACH study, among the 2 million children who were screened, primary screening was done, 8.6% children were referred and 78% underwent detailed evaluation, and out of them, overall nearly 100,000 children had refractive errors, which was nearly 5.5% of children who were screened. And the REACH study in the paper reported state level, residential status and gender specific prevalence numbers. Now, this being the largest data set, the question that came to us was, can we use this data to actually project and estimate what would be the prevalence in all the states of the country, like all 35 states and union territories? So that's what we set out to do. We used 3 data sources. We had the prevalence data from the REACH published paper, not the individual level data, the aggregate results. We had the state populations, which were from the population projections published by the Government of India. And then in order to do the modeling, we used the state level characteristics, which were 131 indicators from the National Family Health Survey of the country, rural urban indicators for each and every state, and the state specific epidemiologic transition level ratios, which is the ratio of non-communicable and injury deaths to the communicable disease deaths for each state. So that is important because myopia is a lifestyle disease these days, as we all know. So this was the prevalence data. It came from 5 states: Kerala, Madhya Pradesh, Maharashtra, Tamil Nadu and West Bengal. So West, South and East India, rural, urban and male, female. 20 data points were there. The population data came from the Government of India sources, and we had to do an estimation for each and every of the northeastern states as well as the union territories, for which aggregate data was given in these estimates. So we used a predictive machine learning model to actually estimate epidemiologic transition ratios for states for which ETLs were not available. So this estimation was also done from the NFHS 5 indicators. And finally, after merging all the data sets into one frame, we used machine learning algorithms to estimate the prevalence in each state of the country. So we ran 3 learners. We ran the Lasso, ElasticNet and Ridge machine learning models. We divided the REACH data set into 75% of training data and 25% of test data. On the 75% of the training data set, we ran three machine learning models, and we estimated the using tenfold cross validation, and then we assessed the out of sample performance in the testing data set, the 25%, and out of these 3, the Ridge machine learning model was performing the best. So we selected this machine learning model, and thereafter we ran the machine learning model 1000 times and estimated the prevalence, age specific, gender specific prevalence for each state, and then we summated the state level prevalences to estimate the country level prevalences. So this was our final modeling strategy, how it was done. Coming to the results, so these are the predicted prevalence of refractive errors in each state of the country in rural females. So we see the highest prevalence was in the northern state of Punjab and the lowest prevalence was in the southern state of Telangana. Rural males, again Punjab is on the right. And if you look at urban, West Bengal was having the lowest prevalence and again Punjab was having the highest prevalence. We obtained the state-wise prevalence numbers, the median number of children who are affected for each state. If you look at overall, in our country we estimate nearly 9.5 million children having refractive errors in the 5 to 19-year-old age group after 1000 bootstrap replications. The take-home message is that if you look at rural versus urban prevalences, the urban prevalences are nearly double the rural prevalences. So this is our summary. Nearly 9.5 million children having refractive errors. Estimated prevalence ranges from 1.8 to 4%. There are wide rural-urban variations. We have certain limitations. The data set only used reach study results. So the challenge is that the urban prevalence may be underreported and private schools may be underreported. So these estimates are an underestimation or more conservative, so to say, for our country. We know that some of these school-based studies have basically reported very high prevalences to the tune of even 15 to 30%. Our own North India myopia study had a prevalence of 15%. So these numbers appear low compared to those estimations. But I mean, we are as good as the data that came in for our estimation, and this is the single largest study on which we could have based our analysis on. So with that, thank you. Happy to take questions.
Thank you, Vivek. It's something new. You have data of 5 states, and using these machine learning tools, you can estimate for all the states of the country. Of course, the basic data should be robust. Otherwise, you may have different challenges. But I'm thinking, can we make it, if we have the similar indicators available for various countries, so can we estimate the data from India is available and from US data we can estimate? Those indicators are available.
I think the major challenge would be having the standard set of modeling level indicators available for all the countries globally. So if you look at some of these like global burden of disease analysis, so these kind of analysis actually leverage national level GDPs and populations and urbanizations and literacy and those sort of indicators to do their analysis. It's essentially kind of a similar approach. They use a DISMOD model and we are using a machine learning model.
Thank you very much. Thank you.
Thank you.
I think with this we can close this session. Do you want a group photograph of the speakers? I think we can join. All the speakers can have a group photograph.